I want to start my questioning on Tricare. I just had a town hall meeting in Montana. Things were brought up that I thought were solved, like providers that couldn't get in the network that offered up but couldn't get. Montana, I think you say this about everywhere in the country. Providers are something we need more of, not fewer of. And then the payments to those providers were not being done on time. So the providers that did sign up weren't getting their checks when they should have. So the question is who has oversight of it will be Tri-West? Who has oversight to make sure, number one, that they're bringing on the providers they need, and this is for you, General Crossland, they bring on the providers they need, and that the providers are getting paid, and by the way, that the money that's actually going out to provide services and not being pocketed by somebody in one of these third-party providers' pockets.
So, Senator, the oversight of the Tricare program is executed out of Defense Health Agency, so that would be my responsibility to engage with Tri-West to make sure they're honoring the aspects of the contract. We do have a pretty aggressive auditing for the last part of the concern that it's actually not going to the provider, but there's potential fraud. We do have a very robust program that looks at and audits that. With timeliness, working harder with Tricare West is what I owe you and the team in Montana to make sure that they're meeting their contractual obligations. With respect to signing up providers, the managed care contractor are given targets. They meet those targets. I acknowledge that when they meet those targets for the beneficiaries, that doesn't always translate that appointments available. So specifically, if you sign up, it doesn't translate that we have actually put appointments out. So in the T5 contract, we've added that as a criteria, not just to sign up providers, but to make sure that there are appointments available for the patients to book with the providers.
So this was a small sample size, but I had providers there that had contracts with Tricare, and I had ones that would like to get contracts with Tricare that couldn't. These were mental health providers. So I don't know what the contract says about the numbers of people you need. I don't know if it's based on population or geography or what it's based on. But I was shocked by what I heard. I was just absolutely shocked. At a time when mental health has been already brought up here several times, when mental health is such a huge issue in this country and we're not bringing on as many folks as we can, doesn't make a lot of sense to me. I want to move on. I want to talk about China. It may strike you as an odd discussion in DoD healthcare, but we have troops in Japan and other places where number one readiness concern we hear about is lack of health care for the dependents and their families and DoD civilians. Apparently, the Defense Health Agency recently barred DoD civilians from receiving care at military hospitals, forcing them to use local hospitals. Wow. I think this it's a disaster, and by the way, I think it's going to, if it hasn't already, end up being an incredible recruitment challenge. We've also heard concerns about a lack of mental health care for dependents in Japan. This stops service members from deploying there, puts tremendous stress on military parents. These reports are concerning and were repeatedly delivered with a sense of urgency from senior military leaders on the ground. It's already been pointed out, China's our number one pacing threat, so this impact on military readiness is alarming. I understand that DoD is now going to make some changes to this policy, but quite frankly, it should have never happened to begin with. General Crossland, was the impact on military readiness taken into consideration when announcing this change?
So, Senator, the change I believe you're referencing was a policy put out on the 22nd of December, and the policy limited the space available access to the system so that we could preserve readiness for the force, specifically saying that Space A would have to call in after 10 o'clock and they would only receive acute care. I've since issued guidance, and a policy was released last week that added clarity to that policy, which expanded care to the Space A. So the policy never targeted or short access for dependents and their family members. It was meant to make sure that they got the priority that they were supposed to get at the expense potentially of space A. So we've removed the barrier for chronic conditions to open up at the community level access within our MTFs for our beneficiaries to include the DoD civilians. We signed that out last Thursday or Friday.
Okay, and so do you believe this fully addresses the concerns of the commanders in the field?
No, I do not believe this fully addresses the command of the field. I think the concerns are broader than the care that the Defense Health Agency is resourced to provide. So specifically in Japan, if you have a hospital, then all beneficiaries, active duty family members, in partnership with Tricare ISOS, receives care from the host nation. I believe that that is also part of the concerns that are being raised.